Bismillahirrahmanirrahim. I send you greetings from California. I'm also grateful to Naila for inviting me to participate in this conference. She asked me to talk about the golden minute, but as time has gone on, the golden minute has become the golden hour, and combined together, they are called the golden period. And that is what I'm going to talk about in the next 20 minutes or so. It is said that we are never closer to our death than on the date of our birth. And in fact, as you can see here in the graphs, the highest mortality is within the first few days of life, and particularly on the first day. About 1 million babies die annually on the day they are born, and that constitutes about 40% of the neonatal mortality rate. What about Pakistan? In Pakistan, a neonate dies every 2 minutes. That's 720 babies die every day, and of which nearly 300 die on the day of their birth. If we are going to change or introduce a game changer, then we must carry out the golden period well. I have no conflict of interest and nothing to declare for this talk, but except to say that because of reduction of time from the administration, I'm not going to address the physiology, which I was going to do before. I'll curtail myself to talking about the golden minute and the golden hour. I will also touch, but not go in detail because of time, what needs to be done and who does what and when, and also the practice points and research directions which are useful in developing this field further. So let's take some basic facts first. In utero, the baby is blue and not pink. And that's a fact which we need to remember. Saturation is around 50 to 60%. Pulmonary resistance is high. Cardiac output is low. Within few minutes of birth, the baby has to move from saturation of 50 to 60 to a saturation of about 85 to 90, and introduce a fall in pulmonary resistance and increase the cardiac output. Now, most babies, the vast majority, do it smoothly within the first few minutes of birth. About 1% of term babies and 15% to 30% of extremely preterm babies have difficulty during transition. These numbers vary depending where you are, but these are mainly Western figures. So why do we need to talk about the transition period? I think whether we are in the West or in low and middle income countries like Pakistan, what we do during the transition period, or what we do not do, may not only be a matter of life and death for the baby, but it may affect their whole future life. And that is what makes the golden period so important part of our life. Sadly, I will not discuss much physiology except for 1 or 2 slides. But before we do that, let's see where this concept of golden minute came from. Maureen Reynolds in 1988 described this in neonatology, but she adopted it from Cowley, who was practicing it in adult resuscitation for a number of years. But the basic thing comes from Formula One racing model, where when a racing car comes into the pit, the 4 tires are changed, the full tank is filled, and all this happens within 1.8 seconds. Now, can you believe that? That 4 tires are changed, a full tank is filled, all this happens in 1.8 seconds. And that is why, because the principle being is getting the right people, allocating the role for each one, and being prepared and working in a standardized manner with the aim of continuous improvement. And that is the basis of the golden minute. So what are the 4 things which we need to do during the golden minute? Establish lung aeration, cord clamping, oxygenation, and circulatory support, in that order. So the most important thing as far as the baby is concerned is transition from a fluid-filled lung to an air-filled lung. And that process happens as soon as labor starts. Labor induces release of cortisol, epinephrine, vasopressin, and increases the lymphatic drainage by 30 to 40%, and also allows the surfactant to reduce the surface tension in the alveoli and compress and take the fluid out. Now, this process starts at the initiation of labor, but may continue for 48 hours or sometimes longer, depending on how the baby has been delivered. Now, I can show you this to you in a beautiful radiogram. Here you can see the lung is black. It has no air in it, and there's no pulmonary circulation. And as soon as the lung gets whiter, there's pulmonary circulation because the pulmonary resistance has fallen and the cardiac output increases. Now, the baby itself does that, taking deep breaths and crying, which we all look for at birth. So the baby cries, inhales a lot of air, and it starts to develop a functional residual volume. Preterm baby, on the other hand, whimpers. It doesn't really take in a deep breath. It hasn't got enough surfactant, and it cannot reduce the pulmonary pressure, pulmonary resistance, or the cardiac output. So why do preterm infants often fail during transition? There are basically 3 or 4 reasons. One, the immaturity of the respiratory control centers in the pons, as you know, there are. But more importantly, they have a very strong Haringira reflex, which prevents the stretching of the lungs, and so that the lung volume suddenly doesn't increase. And the softness of the thoracic cage, and paradoxically, when we breathe in, our chest moves out, but in fact, a preterm baby, when he or she tries to breathe in, the chest moves in because of the weakness of the intercostal and diaphragmatic muscles. But that is a protective mechanism, because if that was not so, the baby might try to compensate by breathing fast. And as you all know, I'm sure, that all neonates need a baseline CO2 around 40 millimeters or 6 kilopascals for respiratory activity. If the CO2 level falls below this baseline, then apnea occurs. So if the preterm tries to breathe very fast, it may induce apnea by reducing its CO2 level. So we must learn this lesson from the baby. When we try and help these babies during transition, we should try and avoid excessive stretching of the lungs by not giving high PEEP or PEEP as it will inhibit breathing. Also avoid high tidal volume or respiratory rate, pushing the CO2 down. So we need to learn physiology so that we can copy it in our process. How do we normally help these babies? Well, there is a big debate whether we should be giving inflation breaths to open up the lungs, or we should apply immediately a distending pressure. There's a huge transatlantic divide. In Europe, the recommendation is 5 inflation breaths, 2 to 3 seconds each, pressures of 30 in term infants and 25 in preterm infants. In the United States, across the Atlantic, they do not recommend inflation breaths. And this is based on Harishkar Palani's work, where the SailS study, which showed that it makes no difference. And in fact, perhaps inflation breaths increase slightly the chances of lung injury. Thus, the current recommendation is to use distending pressure, CPAP, as early as possible in the delivery room. It has many, many advantages. It increases the intrathoracic pressure during expiration through the narrow glottis, and it also keeps the lung, avoids the paradoxical movement of the chest wall of the preterm infant. And so current recommendation is to use CPAP as early as possible in the delivery room. What about cord clamping? It's fashionable to talk about it at the moment because there are lots of research papers being published, but what are important facts? With physiological closure, that means when the duct closes, the cord closes by itself, 40% of fetal cardiac output is diverted to mainly the vital organs, the lung and the brain. And 50 to 75% of placental transfer occurs within the first minute of birth. And so it is important that we let this placental blood flow go into the baby during the first minute. With intact cord, if you don't clamp the cord early, there is an 84% increased chance of baby having spontaneous breathing. So not only that delayed cord clamping allows the blood volume of the baby to increase, but also helps the baby to initiate breathing. Whilst it is now well established, and I'm sure all of you practice, that in term infants, the cord clamping should be deferred for 30 to 60 seconds, or some people say even longer. But is it also true for very low birth weight infants, like less than 28 weeks preterm? And what about cord milking, which is very fashionable at the moment? This cartoon is what I have, my impression is of what the current literature suggests. If you have term or late preterm infant, vigorous infant, not requiring resuscitation, delayed cord clamping for more than 30 to 60 seconds. If the baby is non-vigorous, but term or late preterm, then cord milking may be helpful. What about preterm infant? If the preterm infant is vigorous and not requiring resuscitation, whether it's the 34 weeks or long or greater, then you can delay cord clamping for 30 to 60 seconds. But if the preterm infant is non-vigorous and you cannot you think you cannot wait for the 1 minute, which is so important, and you will consider giving the blood volume to the baby, consider milking, then before you do that, you need to ask a question. What is the gestation of the baby? If the baby is 28 weeks or more, then it is reasonable to try and give cord milking. If the baby is 28 weeks or less, there is no advantage in cord milking. So it is very clear cut now as to what we should practice. But I am much more impressed by the Swedish researchers who asked the question, what is the optimal order of events in the delivery room for infant born preterm? Should lung aeration come first, or should cord clamping come first? And this is what they call physiological cord clamping. And in a study, they showed that if you wait to clamp the cord till the baby has started taking a breath, you get much better heart rate, your saturation improves much faster, you require less FiO2, your cerebral perfusion is better, and if you need ventilation, you require less mean airway pressure. So I'm much more inclined towards physiological cord clamping, but I am aware that our journey towards understanding the best approach to cord management at birth for infants at the highest risk is not yet complete. We will keep on learning a few more things. The next thing is giving oxygen. Remember again, as I said, the fetus is blue in utero, and there is other factors which keeps the baby blue and may prevent smooth transition. Is what was the maternal oxygenation, the hemoglobin concentration of the baby himself or herself, and the concentration of fetal hemoglobin. As you know, fetal hemoglobin does not release the oxygen easily. But even long time ago, it was shown that majority of the babies, majority of even preterm babies, this is a study of babies at as low as 850 grams, the vast majority obtained an 80% saturation by about 3 to 4 minutes. So, and this has been confirmed more recently in 2019, that most babies, whether they be term or between 37 weeks or more, or 32 weeks or less than 32 weeks, majority achieve a saturation of 80% within first 3.5 minutes. So all spontaneously breathing infants achieve 80% saturation within less than 5 minutes. So then why do we give oxygen? But the fact is that 80% of less than 28 weekers or less than 1,000 gram infants receive oxygen in the delivery room. The reason we think is that we need to achieve the target saturation, pre-ductal saturation of more than 80% and a heart rate of more than 100 by 5 minutes. We need, giving oxygen helps in surfactant release, giving oxygen induces pulmonary vasodilatation, and that is what we want. But most importantly, is we want to prevent cerebral hypoxia. Now, the Polish chemist who discovered oxygen called oxygen the elixir of life. And 130 years later, a British physician, Joseph Priestley, said, oxygen may be an elixir of life, but it is also toxic. And today, in 2024, we often forget that lack of antioxidant, particularly in the preterm infant, giving oxygen may induce oxidative injury, induce ROP, BPD, NEC, and IVH. So we have to be very careful as to why we give oxygen, when we give oxygen, and how much should we give oxygen. But Allah is great. And it's a fascinating physiological fact that 80% of saturation in the brain, oxygen saturation in the brain, is achieved during the first few seconds of transition. So brain gets preferential treatment for oxygen supply. And also, interestingly, that if a baby is hypoxic, then there is a very rapid rise of cerebral oxygenation. Well, if the baby is not hypoxic and normal, there is a slow and gradual rise. SubhanAllah, how Allah has tried to give our physiological basis on which to prevent the baby's brain damage from lack of oxygen. So there is really something which we need to remember. Now, so the question was, what is the right concentration of oxygen for term infants and what we know? Well, we know that less than 30% or more than 60%, there is no difference in mortality or short-term morbidity or even long-term neurodevelopment outcome. What does make a difference is that whether you achieve a 5-minute pre-ductal saturation of 80% or more, if it is less than 80% at 5 minutes, then there is increased death and IVH, decreased heart rate and cognitive scores. What we do not know is what happens if we don't give 31, but give 40, 45, or 50%, 59, up to 59%, not quite 60%, or whether we give 70%. So we haven't got those studies. And we also do not know what the ideal saturation should be in a baby of 30 weeks or less. So the current recommendation is it is important to use appropriate, and we do not know what is appropriate amount of FiO2, and it titrated with the saturation to avoid hypoxia and hyperoxia and bradycardia. Two practical points: oxygen delivery should be reviewed and titrated every 30 seconds. Class C evidence, but that is how closely you should be monitoring oxygen supply and sitting with the baby. And it takes about 19 seconds for the saturation to change once you have dialed up or down of your FiO2. This is the recommendation. You can find it in any textbook. What about circulatory support? Interestingly, in a very large study of nearly 5,000 babies, the first about 6 minutes or so, the babies remain a little bradycardic, heart rate remains less than 100. But within 60 seconds, in the vast majority, 82%, the heart rate goes up to 100 or more. So again, if the heart rate is less than 100, but the baby is otherwise breathing, there's no hurry to try and get this heart rate going faster. 25% of newborns hold their heart rate below 100 during the first minute, of which 95% do not require any resuscitation. And the fourth thing about in the first minute is temperature control. Make sure that the baby does not get hypothermic, because if the baby does get hypothermic, the mortality is around 28%. And you know why the babies do get hypothermic. I don't have these are textbook things. I've taken from our own textbook. So these are very, very well known. What about the golden hour? Now we've passed the golden minute. We continue with the temperature control, prevention of hypoglycemia, monitoring, and record keeping. In the United States today, 4 out of 10 infants admitted to an ICU are hypothermic. And you can see that those babies who are hypothermic have a much higher mortality than those babies who are normothermic. So it is important to maintain good delivery room temperature, maintain baby's temperature, and prevent hypothermia by any means you can. But something which we often forget is that during pregnancy, 70% of maternal glucose goes to the fetus. 30% is used by the placenta to generate energy. However, as soon as you clamp the cord, the placental supply of glucose to the baby stops, leading to a transitional, very short-term hypoglycemia in the baby, which lasts for about first 2 to 3 hours. But as it triggers the counter-regulatory hormones, the baby regains its glucose level. So it is important to try and prevent this transitory hypoglycemia, which occurs in the first 2 hours of life. The problem we have, as usual, is we have no consensus as what is hypoglycemia. Here are 1, 2, 3, 4, 5, 6 authorities, and they have all had different definitions of what is hypoglycemia. Fortunately for us, whether we use the lower threshold to treat or the higher threshold to treat, the outcome is the same. The question is, we should not let the baby get hypoglycemic, whichever level you use in your practice. Very, very quickly, because I don't have time, there is now much more improved monitoring in the delivery room in most of the Western countries. You have near-infrared spectrophotometry, echocardiometry, electrical cardiometry, and oxygen saturation index. All of these things are, and increasingly, more and more things are being monitored. But interestingly, there was a very interesting study by Karpani in Nature just in January of just a year ago, who asked the fellows in developing world what monitoring guidelines you need during delivery room. And he asked the same question to fellows in developing world. In the developing world, they said that they will be happy with the heart rate, saturation, and temperature, whereas in the developed world, they wanted video analysis of lung aeration, lung volume, wireless vital signals for heart rate, respiratory rate, and nerves and other things. As I said, I haven't got the time to go through this. What needs to be accomplished within the golden hour is textbook stuff. You will find it everywhere. You'll find it in many, many papers. We need to do many things. We need to have respiratory support, cardiac support, make sure we prevent hypothermia, prevent hypoglycemia, practice delayed cord clamping, prevent nosocomial infection, if necessary, send the lab work. But the important thing is we need to have a team, and everyone should know what they should do at what time. And again, you will find this in many textbooks, and in our own textbook, you will find what the fellows are attending should be doing within a time frame, which is given here on the left, what the nurses should do, what the assistants should do, and if you have respiratory therapists and all that. But to make sure, please, that no job is finished until the paperwork is done. So please make sure that you document well and document it in as much detail as possible. But while you cannot do all that which I have just suggested, what the main game changer is, ladies and gentlemen, and I'd urge you to do this, is to standardize your golden period bundle. Make sure that you have a written protocol of practice for the golden hour, because if you know that it leads to improved outcome, reduces mortality, hypothermia, hypoglycemia, and all the morbidities. And this has been shown by not one, but hundreds of quality improvement studies. So please try and establish your own protocol according to your resources. I'd like to end with this take-home message. In preterm infants, saturation above 85% and a heart rate of 100 or more must be achieved by 5 minutes. Avoid using high inspiratory pressure, tidal volume, or respiratory rate. Titrate oxygen every 30 seconds till you get the target saturation. Early application of CPAP is better than giving inflation breaths. Maintain infant's temperature. Increase use of oxygen blenders and pulse oximetry in the delivery room so that you can titrate your oxygen very well. Establish a trained resuscitation team. Arrange a huddle before every high-risk delivery, and develop your own institutional golden period guidelines. I thank you for your attention. My overall message is, remember, whatever you do or not do may not only affect the matter, be a matter of life and death, but have a lifelong effect on the baby. Be gentle. Thank you.